He's a Doctor of Medicine and Master of Science in Clinical Epidemiology from the University of the Philippines. She was the president of the PRA, or Philippine Rheumatology Association, from 2006 to 2008. Professor of UP College of Medicine and the chief of our Division of Rheumatology since 2016 in the Department of Medicine at UP-PGH. She is a mentor, colleague, friend, and someone who I've known for decades. And it is such a privilege to introduce her as she delivers her Diamond Professorial Chair Lecture. Ladies and gentlemen, Dr. Evelyn Salido.
Good morning. Thank you, Eric, Dr. Amante, for your introduction.
Cheers.
And thank you to the audience here and in Zoom. And I'd like to start by thanking certain people, very special, in the production of this lecture. Cut off the press at all 1 hour ago. So first of all, Professor Emeritus Clemente Amante, who instilled and encouraged my love for research. Chairman Dr. John Aguinaldo for being instrumental in the granting of the professorial chair. The UP Manila and UPCM administrators, the Division of Rheumatology, most of whom are here today. Thank you very much for being here and sharing this honor with me today. Especially special mention would be Professor Esther Penserga, who started the RADAR, that's the Rheumatoid Arthritis Database and Registry, in 2009. Professor Michael T., our new chancellor, also a leader in research. Dr. Eric Amante, and our former fellows, now alumni, Dr. Junette Pipe and Dr. Mark Andrianiano, as well as Dr. Kenneth T. Special thanks to them because their research inspired me and became the spur for this professorial chair lecture. Also to acknowledge the section of Rheumatology UST, specifically Professor Sandra Navarra. If you Google lupus in the Philippines, you will see that she has most of the studies, seconded only by Dr. Michael T. Baka overtake sometime in the future. Also to thank Dr. Juan Javier Lichalpo from the section of rheumatology of St. Luke's Medical Center. So I'd like that at the end of this lecture, the audience will have increased awareness of increased cardiovascular disease in immune-mediated inflammatory diseases, to understand the etiology of increased CVD risk in these diseases, and realize the importance of treatment of both CVD risk factors and optimal anti-inflammatory therapy to achieve CVD risk reduction, and to be able to appreciate information that we have on CVD among Filipinos with inflammatory arthritis. So my real purpose is to inform, but hopefully I can challenge and spur some of us to action in order to do something about this problem and learn more about it so that we can face it head on. When I speak of immune-mediated inflammatory diseases, usually we call them CTDs, connective tissue diseases. This is a group of diseases wherein you have dysregulation of the immune system resulting in chronic inflammation in certain tissues. And characteristically systemic involvement. So I am focusing on these three diseases: rheumatoid arthritis, ankylosing spondylitis, and systemic lupus. And you can see that how common the chronic inflammation, there are differences in genetics, in environmental factors that initiate the pathogenesis. There are differences in the cytokines that you see in the table, and the pathology also differs. Whereas rheumatoid arthritis primarily causes synovitis in peripheral joints. In ankylosing spondylitis, it's more of an enthesitis. But both conditions can eventually lead to bone erosion. In systemic lupus, the primary problem is the deposition of immune complexes in tissues, resulting in damage. You will also see that the demographics differ. Rheumatoid arthritis is threefold more common in females, affecting those who are in their 4 to 6 decades of life. Whereas ankylosing spondylitis used to be known as being more common in males, it is now thought that there is almost a 1-to-1 ratio between males and females. And I think we are now understanding that although it may be difficult to diagnose in females, it can occur as frequently in them. And lupus also occurs in young people, predominantly females, very, very high female preponderance. And you will see also that the main clinical manifestations differ. Whereas AMP is more of a peripheral polyarthritis, ankylosing spondylitis affects more the axial skeleton, primarily sacroiliitis, although there may also be peripheral joints. And lupus, we are more familiar with lupus, which has multisystemic involvement. So the prevalence also differ. I just so that the denominator will be the same. I used 100,000 as the denominator. We only have data for rheumatoid arthritis among the Filipinos. That's 600 per 100,000 Filipinos, and this is data that is 20 years old. No? Ankylosing spondylitis is, as you see, more than 100 per 100,000 people in Asia, and lupus is 30 to 50 per 100,000. But if I think of my patients in my clinic, I will say I see as many lupus patients as rheumatoid arthritis, and very rarely do I see ankylosing spondylitis. Although during the recent maybe 1 to 2 years, there are more of them. It used to be that I see 0 to 1 in a year, but now I see almost 1 per month. So that's how infrequent ankylosing spondylitis is in the Philippines. But common to these diseases is the exciting data that there seem to be increased CVD risk and mortality. So to approach these inflammatory diseases holistically, we don't only think of their arthritis and the chronic pain. We look at all the things that I have here in the slide, no? The organ damage, the physical and the mental disability that can go with it. And we know that since we usually give immunosuppressants also, aside from the immune dysfunction in these diseases, we also have the immunosuppressants that we give, so they are at risk for all sorts of infections. And because we appropriately have to do polypharmacy, no? Then we watch out for adverse drug effects. So may nadagdag pa na chronic na cardiovascular disease. So I'm trying to put that forward in our awareness. No? Although, so there seems to be a lot of excitement in research in terms of CVD associated with these inflammatory diseases. And speaking of rheumatoid arthritis alone, in a review spanning 20 years, there were more than 2,000 articles and reviews published, and there is yearly increase in these publications concentrated in North America, Europe, and East Asia. And the US is the top contributor, followed by the UK and Italy. You see GDP serving as an important factor here. And the research hotspots are clinical features of the CV events, mechanisms, risk factors, how drugs affect CV safety, and we see future research as looking into safety and CV pharmacological mechanisms of disease-modifying drugs, especially the targeted synthetic ones. So what do all this research show? In short, it really the mortality ratios are increased, and it seems to be similar to that of DM type 2. So it's really a big concern for us. And this increase in cardiovascular disease is mostly myocardial infarction and stroke. This is a study in Norway. So they have a 20-year study looking at trends in all-cause and cardiovascular mortality in patients with rheumatoid arthritis. And I'm just so envious that, they have a big RA registry, and then they have a Norwegian cause of death registry, and they can just play with their registries and look at the trends. So they were able to show that the predictors for increased 10-year mortality for all-cause mortality and CV disease were increasing age, male gender, low level of education, deprived area of residence, and rheumatoid arthritis. And that all-cause and CV mortality increased higher in the older cohorts, those who had rheumatoid arthritis 90 in the years 1994 to 1998, those who had incident RA in the latter years, probably because of better awareness, shorter delay in diagnosis, and hopefully better treatment. So if you look at these graphs, the solid line will be the controls, and the broken lines will be those with rheumatoid arthritis, and the one at the left, all-cause mortality, and the one at the right, CV mortality. And just looking at the comparison of the solid lines and the dotted lines, you see that in whatever cohort, there is a higher all-cause and CV mortality among those with rheumatoid arthritis. And well, I'm sorry, it's a little bit time to process, but take my word for it that the mortality is increased in this, and they showed that those who were diagnosed earlier fared worse. So we're in a good time to be, this is a good time to be doctors. So because of these trends in increased cardiovascular deaths and cardiovascular disease, there have been a lot of studies on predictors. Now, of course, we want to predict, want to identify and stratify patients for rheumatoid arthritis patients according to their CV risk. And these are just some studies that I saw. And there are a lot more. Parang I won't finish preparing for the lecture if I look at all of these. So these are just new ones. And this is exciting because this study compared different predictor scores, CVD risk calculator scores with the coronary artery calcium. And it showed, which is a marker for atherosclerosis. And it showed that one of the scoring systems, the ERSRA, excuse me, show the highest correlation coefficient, showing a positive association with the coronary artery calcium score. But that was a small study, so there really has to be more that should follow. Okay. So what about ankylosing spondylitis? Ankylosing spondylitis, the data is not as definite as in rheumatoid. Maybe because the population is smaller, but you will see here that hypertension is the prevalence of hypertension is high, and there are a lot of conduction abnormalities which occur in ankylosing spondylitis, and they have proposed that these are not related to disease activity or gene markers, but basically obliterative endarteritis of the small blood vessels that supply the AV node and the aortic root. And patients with ankylosing spondylitis, even those without clinical evidence of heart disease, we should be careful of them because the aortic roots are less elastic than in healthy control. So they are really at higher risk of having problems with such as aortic insufficiency. So cardiovascular mortality in AS, the data, the risk for ischemic heart disease and acute MI are not consistent, but many of them show increased risk for these diseases. And the same is true for all-cause mortality. If you're interested, I can share my slides with you. So, what about lupus, no? CVD in SLE? In 1997, a study was done looking at female patients with lupus, comparing them with Framingham historical controls. And they found that among women who were aged 44 to 50 years, there was a 50-fold risk increase for MI and a 7-fold risk increase for coronary heart disease after adjustment for risk factors. So we should really pay attention to this aspect in the care of patients with lupus. Further, a new meta-analysis two years back showed that compared with the general or healthy population, the risk of CVD in SLE patients is 2.35, no? With confidence interval 1.95 to 2.84. So really a significant increase in risk. If you look at, because there was significant heterogeneity in that meta-analysis, and if you break down into the different cardiovascular diseases, they show that there indeed is an increased risk of CVD with SLE. About mortality. So this is a study published early this year looking at causes of death among individuals with SLE, and this was in the US. So they looked at the California Lupus Surveillance Project. They had 812 patients with lupus who were residents of San Francisco County. And they had, the observation period was January 2007 to December 2009. I think that was the time when they were diagnosed to have lupus. And again, they matched these cases with controls, and they looked at the National Death Index. And they showed age-adjusted differences in causes of death by race, ethnicity, and sex. and they look at age standardized mortality ratios comparing lupus versus the general population. So let's look at this. This is very interesting for me because if you look at what is observed, no, compared with the expected CVD deaths, so dapat 12.4 lang. But in lupus, it's 45. So that's 4 times the risk, no? And if you look at the different races, pinakamataas yung Asian, no? 3.83. Yung standardized mortality ratio. For ethnicity, it was higher in Hispanics and it was a bit higher for females. So why so, no? Why so? An increased CVD risk in these inflammatory diseases. So we see this diagram showing us the traditional CV risk factors. So what we know, hypertension, diabetes, obesity, and we also have the chronic inflammation going on, plus the anti-inflammatory therapy that we give, leading to success of endothelial dysfunction, plaque remodeling, instability and rupture, and accelerated atherosclerosis, leading to the increased CVD risk. So that's the general idea. Looking at this, I labeled this as inflammation in atherosclerosis. But if I look at it closely, it's very similar to what our fellows lecture every Monday in our basic Roma lecture, inflammation. So if you see here, the blood vessel, and you have a lot of processes occurring. So so first here, this is the inflammation and atherosclerosis. You have LDL being retained in Kima, and in the presence, you have a lot of monocytes being attracted, and the die, and these are taken up by these macrophages, leading to the formation of foam cells, which release pro-inflammatory cytokines, leading to further inflammation. So isn't that very similar to what we see in rheumatoid arthritis? So in this process of inflammation in atherosclerosis, if we summarize it, it's common with endothelial dysfunction. There is inflammatory activation of the endothelial cells, coupled with dysregulation in lipid metabolism, followed by activation of adaptive immunity. So it parallels what you see in rheumatoid arthritis. If you don't know what's happening in rheumatoid, it's very similar to this. It's just happening in the same way. Okay. So, in addition, so in patients with rheumatoid arthritis, the proposal is in addition to the traditional cardiovascular risk factors and the increased systemic inflammation, decrease in endothelial progenitor cells, there is also genetic predisposition. All of this leading to premature atherosclerosis, leading to the cardiovascular morbidity and mortality. But we also, as part of the increased cardiovascular factors, hypertension, we think of the drugs that we give, like corticosteroids, COX-2 inhibitors, and leflunomide, which can all aggravate the presence of hypertension. Also, there is the lipid paradox. Did you know this already? Because this is something which I heard before but did not really fully understand. But because of this lecture, I learned it more fully. So lipid paradox, in patients with rheumatoid arthritis with active inflammation, you may not see an elevation in your LDL and in your total cholesterol, and you might see an elevation of the HDL, which should be good, right? But lipid paradox. Um, People with a seemingly good lipid profile can still have increased cardiovascular disease occurrence. So, and that is also, there is also what we call the obesity paradox, that they look lean, they're not overweight or obese, but they still have increased CVD occurrence. So it tells us that we don't only, we shouldn't be kampante, no, when we see these normal results in BMI and the lipids, and we still look more closely at them, okay, in terms of cardiovascular disease. So let me now shift to ankylosing spondylitis. These are processes that all occur also when we have accelerated atherosclerosis. And studies have shown increased cardiac media thickness in patients with ankylosing spondylitis, which is a marker for atherosclerosis. In addition, many of our patients with AS are on chronic anti-inflammatory therapy because after NSAIDs, ang next naman ay biologics. No? In our algorithm, if you have atrial involvement after non-steroidal, the next if that doesn't work, then the next step should be biologics. And you know how resources are limited in our setting, and not many can really avail of these biologic treatments. So a lot of patients are on NSAIDs. The also have chronic inflammation. With the chronic inflammation in ankylosing spondylitis, uh, I already mentioned earlier, no, yung reduced elasticity of the aorta. So there is aortic, aortic insufficient. I already mentioned production abnormalities. There may also be myocarditis and reduced left ejection fraction. Okay. So each of the three diseases have their own roots. With AS, there's the involvement of the aorta. Okay. But in lupus, uh, I'm sure the residents see more lupus than RA and AS. You probably just see AS and RA in the when you rotate for 2 weeks in our division, but you see SLE only. So for SLE, these are also the traditional risk factors. We know this already. But they're also in SLE is that lipid paradox, you know, the same as we see in rheumatoid arthritis. And other non-traditional risk factors, one of them would be the presence of anti-phospholipid antibodies, which are present in maybe 30 to 40% of our patients with lupus. So, blood testing is a bit pricey, but it's something that we should not forget because knowing that our patients have anti-phospholipid antibodies will translate to doing something different in our treatment. Among the SLE manifestations, nephritis has also been significantly been related to the occurrence of cardiovascular diseases, no, use of corticosteroids, and the low levels of natural antibodies, including anti-phosphorylcholine. Looking at the right side of the screen, you see several things that are common in SLE and atherosclerosis. So the presence of the traditional risk factors, the atherosclerotic plaques, aberrant clearance of dead cells. That's also a process that occurs in atherosclerosis and is a key process in lupus. There also is LDL oxidation. Okay. But in addition to this, in lupus, we have the prothrombotic state because of the antiphospholipid antibodies and low levels of the antiphospholipid antibodies. Ano ba yun? Do you know that? Anti-PC, antiphospholipid. I discovered that antiphospholipid is a protector. No? Its presence protects you from atherosclerosis. And it seems that in lupus and in patients with atherosclerosis, this is reduced. So because of all of this talk about cardiovascular disease and inflammation, there are several studies looking into whether anti-inflammatory therapy can be treatment for atherosclerosis. So this is, I'm very sorry for the, what happened?
Bueno.
So, so at this point, ito na yung 12 midnight. So I'm sorry for the hurried slide. But this is just to give you an idea of the several randomized control trials that have been done over the past 5-7 years, looking at the role of anti-inflammatory therapy for atherosclerosis. So this focused on colchicine, 0.5 milligrams per day, and there were 2 studies on that. The publications were in 2020. And one was the LODOCO, which is a smaller study of 500 plus patients with stable PAD. And the other one is the CAR2, LODOCO2, which involved more than 5,000 patients with chronic coronary disease. And they gave colchicine 0.5 milligrams per day versus placebo, and it seemed that there was prevention of recurrent cardiovascular events. So I will be honest and say I was not able to appraise the articles, but I saw the ESC, European Cardiology Group, including colchicine as a possible drug for those patients with CVD for secondary prevention. Okay. But another interesting study that I found was the CIRT, which is CV Inflammation Reduction Trial. Almost 1,000 patients with history of MI, coronary artery disease, diabetes, or metabolic syndrome, given methotrexate 15 to 20 milligrams per week compared to placebo. And this was a negative study. They stopped it after median follow-up of 2 years. And there were adverse events referable to the liver, to the blood, leukopenia, anemia, and increased incidence of non-basal cell skin cancer. Okay. But another one is the CANTOS, which is canakinumab. No? So this is a big study, 10,000 patients with previous MI and HSCRP, more than 2 milligrams per deciliter. So canakinumab is an anti-IL-1, and it was given in 3 doses, different doses, subcutaneously every 3 months, compared with placebo, and the study went on for 40 months, and they saw some reduction in cardiovascular events. Another study was ASSAIL-MI, the effect of anti-IL-6. So we are familiar with tocilizumab for critical COVID. And in this study, which the results of which were published last year, they studied almost 200 patients with STEMI. Within the 6 hours of symptom onset, they looked at the myocardial salvage index, and they gave one infusion of 280 milligrams tocilizumab versus placebo and achieved lower myocardial salvage index. Very interesting. And another drug that we're familiar with in rheumatology is tofacitinib, which is a JAK inhibitor. So the oral surveillance is a post-marketing, is an extension study looking at active patients with rheumatoid arthritis, active rheumatoid arthritis, and they found increased risk of MACE versus compared with the TNF inhibitors. And although recent in vivo studies showed seeming favorable impact on macrophage cholesterol metabolism. Okay, so these are very interesting. And this is the recommendation in this is the one that I was telling you about from the ESC guidelines. So they said that those colchicine may be considered a secondary prevention. CBD, particularly if other risk factors are insufficiently controlled or if recurrent CBD events occur under optimal therapy. So at this point, let me share with you a few studies of CBD that we have. No? So there are two that I'll share with you today. So one was published in 2019, and the other one by Dr. Yano is still unpublished and hopefully will be published. Okay. So these two studies were both retrospective cross-sectional studies. They both studied patients who were adults and with rheumatoid arthritis based on classification criteria. And they looked at these different traditional CV factors. Their definitions were very similar, except that the latter study done last year included the use of medications in the definition of the diseases. Okay. Okay. So first, look at the left upper hand corner, showing you the characteristics of the persons or the patients included in these two studies. So the study by Dr. Hipe had data collection from 2009 to 2013. So that's 5 years, 6 years. And that of Dr. Yano, 2019 to 2022. So they had about 100 patients each, predominantly female, predominantly middle age, mean, and most of them had previous employment. No? And a few, well, a lot, had family history of hypertension and cardiovascular disease. Many of them are seropositive, no? Rheumatoid factor positive, and still with moderate disease activity for rheumatoid arthritis, despite many years of follow-up. Okay. Now, looking at the right side of the screen, we see here the additional risk factors. So, it's good that smoking is there, but not very high. But hypertension and diabetes and being obese and overweight are there. And what we see in dyslipidemia, around 40 to 50% have dyslipidemia. But here, I don't know if this reflects the lipid paradox. We see a lot having low LDL, low HDL, high LDL, and high total cholesterol. So that's it in a nutshell. So the study of Dr. Yano looked at causes of cardiovascular diseases, and there were 12 of the 123, so almost 10% had documented cardiovascular disease. So these are the obvious ones. So I wonder if we did further screening, if we would have found more. Okay. So studies in cardiovascular disease in lupus. We have these studies, but I will share with you two. These are one from UST looking at risk factors for stroke among Filipino patients with FLE. This was published in 2005. They had more than 400 patients with lupus, and 25 of them had a stroke. And they looked at these risk factors. So hypertension, dyslipidemia, nephrotic syndrome, CNS, extra CNS vasculitis. So those are also a lot had family history of thrombosis and low complement. Okay. So this is the other study by Chancellor Mike T, which looked at necropsy findings and cardiovascular involvement in lupus over 40 years span from 1964 to 2003. And they had 64 patients, and these were the most common findings that they had. But if you look at atherosclerosis, 11%, and coronary artery disease already narrowed coronaries into patients. And these were relatively newly diagnosed patients. Okay. The next slide is very busy. Ayaw niya nang mag-move. Takot dun sa sinabi ko na busy slide. Ito. Okay. Well, this is just to show you studies looking at prevalence of dyslipidemia. Nakakatuwa ito, no? Side story. In 2007, there was a lupus congress in Shanghai, and everyone was excited. So in UST, they had a prevalence of dyslipidemia study, and here in PGH, that same year, we also presented a study on dyslipidemia, and you see very high rates, no? 65% and 86% in our study. These were small populations. And Dr. Lichalco from St. Luke's looked at carotid intima media thickness and carotid plaques. So a few patients, but in these 56 patients, he saw that the carotid intima media thickness was normal in all patients, but 8 patients, these were relatively young patients, already had 1 or more carotid plaques. And then the last one at the right is looking at causes of mortality in Filipino patients with SLE. So this is a study spanning looking at deaths over 10 years, 190 patients, and I included this because at the bottom of the line, you see the last bullet showing cardiovascular deaths in 37%, which were mostly among those who had late onset SLE. Okay. So, knowing cardiovascular disease risk is increased, what do we do? No? Do we just screen and do nothing? Of course, we have to manage, and there are several guidelines. Look at how we manage the risk. No? So you can look at them. The first one, the top left, gives us guidelines for patients with rheumatoid arthritis, AS, and psoriatic arthritis. So that was in 2015, 2016. And the one at the bottom left looks at other rheumatic diseases, including gout, lupus, systemic sclerosis, MCPD, Sjogren's syndrome, and anti-phospholipid antibody syndrome. And the one at the right, ito yung European Society of Cardiology guidelines. So they are all out there, to guide us. But I think I don't want to go through the very busy slide anymore. But what all of this is telling us is that we must assess the risk. We must assess the risk. We must manage the traditional risk factors, and we must control the primary disease. No? So yun yung sinasabi nitong mga ito. There are studies which look into whether immunomodulators, because I was saying, control the inflammation. So, diba, the best controllers of inflammation seem to be the new drugs, specifically yung mga biologic agents. Now, this is a study which looked at the addition of tumor necrosis factor alpha inhibitors and compare it with triple therapy among patients with active rheumatoid arthritis. And by triple therapy, I'm referring to sulfasalazine, hydroxychloroquine, combined with methotrexate. And they look at 115 patients, and at the end of this, there was it was true, there was significant reduction in arterial inflammation, but they were not different. So the group given DMARDs had the conventional synthetic DMARDs had the same reduction in arterial inflammation as those given the tumor necrosis factor, the TNF inhibitors. Okay. And this reduction in disease activity, of course, was seen, but was not associated with change in arterial inflammation. So parang nakakabitin, because I was saying you have to control disease activity, but this study tells you that it's not as simple as that. Okay. So this is the 2022 EULAR recommendation. So I'm happy that we already have recommendations aside from RAAS and psoriatic arthritis. We also have management of cardiovascular risk, gout, vasculitis, systemic sclerosis, myositis, MCPD, Sjogren's syndrome, SLE, and anti-phospholipid antibody. Okay. So this is the summary of all of those recommendations that we must exercise caution when we prescribe medications that may contribute to increased CV risk, that we have to manage the CV risk factors the same way as we do for other people. We induce disease remission and control systemic inflammation. We quantify CV risk, detecting early atherosclerosis, and here is the statement early implementation of targeted biologic DMARDs in selected patients. So to end, I hope that even if some of you were multitasking, you were able to appreciate the increased CVD risk in patients with RAAS and SLE. And that when we look at them, we do not only look at their rheumatic disease, at their organ damage, but we also look at the aspect of CVD risk. And we have seen increased CVD risk in Filipinos with RA and SLE. We have few data, but we hope that this will spur people to look into this in more detail. We know that the increased risk is due to inflammation and atherosclerosis, and that we must assess for severe risk factors and manage them optimally to prevent CVD. So thank you very much for your kind attention. And thank you to the division for this opportunity.
Thank you, Dr. What a cutting edge, interesting, and thought-provoking lecture. So we have a few minutes for questions. Now, I just wanted to ask off the bat. So you showed a lot of data. We know that a lot of these patients present in sort of a younger to middle-aged group. So intuitively, we don't really check for cardiovascular risk as much. No? So what do you think are the concrete measures we can do, which we already do maybe for other diseases, in terms of investigating CVD risk and preventative measures? What concrete steps do you think we should all be doing?
For people who are more than 40 or 45 years old. So even if in front of you, you have a patient with RA or lupus who is 25 years old, we include in our assessments the lipids. Even if we see that they are normal, we investigate further, especially if they have family history. And then among our patients with lupus, we check the anti-phospholipid antibodies. No? Even if our resources are few, we can insert it in our plans for the patient. We manage the hypertension well. No, we follow. We monitor their blood pressure very well. We do the usual things that we check when we are looking for cardiovascular disease in a 50-year-old or a 60-year-old. And the studies are showing, I don't know if it's time to really apply the scoring system, no? But some people do that. It's one thing that we can do, maybe validate in our population, no? And see if the ERSRA score is something that we can apply in our population. And patients who seem to be well, because sometimes they look so well and they're not complaining of anything. So, okay na ako, nagagawa ko na yung lahat ng gusto kong gawin. No? Parang they don't want to do, why the heck are you asking me to go for this test? No? To the echo, things like that. Or why are you asking me to see a cardiologist? And you need to explain to them very well. And in the first place, think of those things. So that's the purpose of the lecture. Natin kalimutan.
Yeah, I think it's very important, especially you all know these are chronic diseases, and when you have young patients, it's sometimes difficult for them to continue care and to understand these things. So, ma'am, you showed a couple of studies, Marciano's study and Junet's study. Do you think we can extend those studies or maybe look longer? Because I was thinking maybe we need longer time frames also to assess these kind of diseases.
Definitely. The registry that is what we should do. Well, last weekend we had a PRA activity, so we were all together. And as I was preparing for this lecture, I looked for the head of our rheumatoid arthritis SIG, and I was telling him that, oh, maybe you can ask APLAR Asia Pacific League to come up with an Asia Pacific registry for RA, much like what Dr. Lorenzo is starting for gout in the Asia Pacific. So, makakaingit naman yung gout SIG kasali rin doon. That, they're doing that, and maybe, and I think it's even more important for RA. So that's the way to go, because we have had our efforts here in PGH in establishing the radar, and we need funds for that, no? But it's something doable. in our level,
And hopefully radish can help. The
yeah,
fact that we're doing
here to now that radish, something to be studied.
Oh, I have a question. Interesting. I found that interesting that colchicine in one of your studies. I mean, we all use that for gout, but can you expound on that? What's your theory on why it work for others?
Short answer is I don't know. The usual way colchicine works is that it inhibits the microtubules, so it prevents the PMS from going to areas of inflammation. So that might be one of the ways through which it exerts its anti-inflammatory effect as well.
Next one. Another First of all, I have to leave my other meeting. Post. We have a question would be question of area. Like inflammation is major factor in much of in the in this group patient. Because it has been studied already post fermentation patients thinking of very nice study of patients with inflammatory
Cream. So we should work for that because colchicine is 3 pesos. It can be taken in the equation. So we have what we can start a study.
looking forward to more information. Yes, Katie.
It is interesting. One of the things that we saw with our treatment with biologics, as Dr. Salido pointed out, is that when we start the biologic, there's something that's actually in the needle shifts from what seems to be normal lighting to this lipidemia, in fact. So much so that they had to talk about atherogenicity index, etc., etc. So parang nakakatuwa hindi na nakakatuwa. Kasi it makes for a very interesting thought when we talk about lighting paradox, obesity paradox. There's also a paradox about on one hand controlling the inflammation and then looking at the safety profile of the drug as increasing dyslipidemia. So many questions left unanswered. Pero just want to point out where your talk was going and Paulo and I were talking about what possible studies to be actually true. Because we already have cohorts of patients on colchicine and methotrexate. So it might be interesting to compare what the cardiovascular outcomes already are for patients on colchicine and methotrexate. This would be those who are not conditioned in a different condition. So because I think that was pointing out. So that's really research project natin.
In reference to that also. I remember early on, the drug which a lot of you use tocilizumab in COVID, right? So tocilizumab studies actually show an elevation in LDL very early. There have been some conflicting studies, but in general, they said that it's not so. much in terms of increasing cardiovascular. I just wanted your take on causative itself because it is something that a lot of COVID patients have received. It's something we've used for RA. Showed early LDL elevations.
I was so surprised for the post MA, for myocardial survival. Wow. Kami pa talaga natin hindi alam. So maybe even the next lifetime is not enough. So yung mga kaupo doon ng mga fellows and yung consultants, you have to follow up on this.
Evelyn Senior. Okay. If we are planning to update the dyslipidemia guideline. Special population. Considering the local data that we have presented. I know maliliit pa yung data, but I think we could start with burden of disease. Inflammatory disease, what are the most common risk factors, and you have started. And I think it will be a good reference for that guideline. Kasi the dyslipidemia guideline focuses on general population. As what you have said, 40 years and above the screen, and now you're saying that those with inflammatory disease, even they are younger, we need to screen them. So we'll be focusing on that. Then we can have a burden of the disease study. Baka pati sa hypertension, baka maraming may hypertension. So it will also change the preventive cardiology landscape of the local guidelines. I will raise it up sa PHA Preventive Cardiology Group kasi I'm part of that. Thank you.
Thank you, Dr. Yobs. Wow, nag-lecture lang ako, makasasali na sa guideline. Thank you very much.